In almost every developed nation, mandatory collective health financing dominates. These governments secure coverage by rejecting pure private market dynamics in favor of state-mandated pools. Traditional supply and demand equations reliably clear markets for most goods. A state-mandated universal healthcare system bypasses these pricing mechanisms entirely, creating intense economic friction. Standard economic defenses of this intervention point to market failures. They argue that state mandates solve adverse selection caused by asymmetric information and establish a necessary baseline of social equity. To evaluate how these systems actually function, we have to build a model from first principles. We must trace the mechanics from individual expected utility up through macroeconomic supply constraints. Understanding social health insurance requires deconstructing the mathematical equations that dictate its true price, alongside the political economy that guarantees its existence. At the root of any insurance demand is the von Neumann-Morgenstern risk-utility function. This establishes the baseline mathematical demand for coverage. This framework relies on state-dependent utility. The subjective value of a single dollar changes depending on whether an individual is in a healthy state or a sick state. This chart models that relationship. We plot wealth on the horizontal axis, dropping from a no-loss state, WN, down to a state of loss from illness, WL. The straight line connecting these two outcomes gives us the expected utility. It acts as the strict mathematical average of wealth based on the statistical probability of falling ill. Humans are generally risk-averse. This is represented by the concave curve arching above the straight line. It demonstrates mathematically that a certain, guaranteed amount of wealth generates higher utility than a gamble with the same expected value. This specific point on the axis is the certainty equivalent. It marks the exact amount of guaranteed lower wealth an individual prefers to secure rather than facing the unpredictable risk of medical bills. The distance between the no-loss state and the certainty equivalent gives us the maximum premium. The individual is willing to pay an amount far exceeding the expected loss just to eliminate the risk. Because risk-averse individuals willingly pay premiums above the statistical expected loss to guarantee wealth certainty, there is a permanent baseline demand for health insurance. Private markets attempt to capture this demand but face a structural barrier. In the Rothschild-Stiglitz model, individuals know their own health risks better than insurers do, leading to adverse selection where the sick heavily outpurchase the healthy. Social health insurance theoretically solves this market failure through a single pooling contract. By forcing all risk types into a unified pool, the state neutralizes adverse selection by eliminating the option for low risks to exit. Proponents argue this monopoly yields massive administrative savings. But mandatory social insurance contributions function as payroll taxes. The excess economic burden of these taxes frequently reaches 30%, mathematically neutralizing any administrative savings gained from a single-payer structure. To explain why these systems dominate despite these inefficiencies, we apply public choice theory. State-run healthcare functions as a highly effective vehicle for wealth redistribution. It operates with distinct political utility. The system obscures the redistributive tax component from high earners, while simultaneously and visibly redistributing medical care to pivotal voter demographics. The macro data reflects this dynamic. Examining decades of Dutch government expenditure, economists von Dalen and Swank found that public transfers to social insurance predictably and significantly spike in direct alignment with national election cycles. Social health insurance outcompetes private markets because it allows politicians to optimize their probability of re-election while operating under the premise of correcting healthcare market failures. Moving to supply-side constraints, a citizen's gross premium is a transfer mechanism to cover expected benefits. The true price of operating the insurance itself is the loading. We define the total amount of loading using this equation. It formally deconstructs the structural costs of maintaining the system. The first term isolates mu. This variable represents the per-unit administrative expense required to process each individual claim. The second term focuses on lambda. In a private system, this captures acquisition costs and profit margins. In a public system, it measures the excess burden and inefficiencies generated by the taxation required to fund the pool. Look closely at the inner function, V. This measures an individual's preventative effort. As insurance coverage expands, the financial penalty for getting sick shrinks, causing preventative effort to decrease. This is ex ante moral hazard. When preventative effort drops, the statistical probability of loss or illness, denoted by pi, mathematically increases. Because the probability of claims rises as preventative behavior falls, any expansion of health coverage mathematically forces the loading to increase. The true cost of operating the system inflates before a single patient requires treatment. Once a patient is in the system, we observe ex post moral hazard. Insured individuals consume a higher quantity and quality of medical care simply because they are insulated from the point of sale cost. This graph maps that exact behavior. The inner diagonal line traces the true demand function for healthcare. Where it intersects the horizontal cost line, we find the baseline market equilibrium at quantity A, without any insurance interference. Introducing a 50% coin insurance rate creates a leverage effect. Because the patient pays only half the bill, their maximum willingness to pay limit effectively doubles, pushing the limit from C prime up to C double prime. This physically rotates the effective demand curve outward. A new equilibrium is established on this outer line, resulting in higher healthcare utilization at quantity B. The horizontal gap between the baseline quantity A and the new quantity B represents the exact measurable volume of ex post moral hazard. In social health insurance systems, political pressure consistently pushes to eliminate out-of-pocket expenses for voters, driving co-payments towards zero. A zero coin insurance rate creates infinite leverage. The observed demand curve shifts to a completely vertical posture, maxing out healthcare utilization entirely at point C. Returning to the calculus of our loading multiplier, taking the derivative with respect to coin insurance reveals a strict inverse relationship. As coin insurance approaches zero, the loading multiplier reaches its absolute mathematical maximum. By removing price friction at the point of care, social health insurance systems structurally guarantee an exponential inflation of their own true operating costs. Social health insurance rests on an inherently unstable equilibrium. It is trapped between continuous political demands and rigid microeconomic constraints. The system operates in a continuous feedback loop. Public choice incentives drive politicians to expand benefit packages and eliminate coin insurance to secure votes. These exact policies directly feed exploding loading costs. The exact state that is politically optimal to legislators represents the literal worst-case mathematical scenario for both ex ante and ex post moral hazard. Human risk aversion creates the initial, rational demand for insurance. But by expanding beyond that baseline to optimize wealth redistribution, state mandates guarantee the true price of coverage will permanently strain the underlying tax bases.